So I'm a general internist, which would be considered a primary care physician. So, and I, my research has been in primary care and specialty care, but particularly with an interest in symptoms, things like pain, fatigue, dizziness, as well as psychological symptoms like depression or anxiety. These kinds of symptoms kind of cross all medical and psychological conditions, and they're really quite prevalent in all practices, and that's kind of where my niche is. Well, one way of thinking of it, it's extra help for the primary team. Now, it's been best studied in primary care, but it's also been studied in a variety of specialty care settings like cancer and neurology and places like that, cardiology. And it's been particularly used for conditions like, depression. It's been studied a lot for depression. That's where there's been the most research. More recently, pain and anxiety. We've also been involved in studies that have targeted all of these symptoms, but it's the kind of stuff that benefits a lot from maybe more regular contact early on. Much of it can be done by telephone, educating the patient, monitoring how they're doing, adjusting treatment. The patient still sits in their primary care or their specialty team, but this is another team that provides extra help for what I'd call particularly these kinds of symptoms. I think they've always been prevalent. I think they're often associated with a variety of medical diseases, and sometimes they're the primary problem. Somebody comes in and says, I'm having back pain. That's a common one. I'm having headaches. I'm feeling tired. I'm not sleeping. I'm dizzy. I'm having stomach trouble. These are examples of symptoms. And sometimes it's easy. We do some tests and we find a specific medical diagnosis. And sometimes, half the times, these kinds of symptoms are the primary reason the patient comes in. And even after testing, we're left with treating the headache, the back pain, the fatigue, trouble sleeping. I think these have always been around. They've gotten somewhat less attention, probably, because our training of doctors is very disease-based. Once we find a disease, we're pretty good at treating it. But these kinds of common symptoms, I think both in training, in terms of training as well as our knowledge, it's less perfect. And so I think these symptoms may take a back seat sometimes in practice, but there are evidence-based treatments for it. Interesting, they can be medications, they can be behavioral treatments like exercise, CBT, but educating patients about it, monitoring them, seeing if they're getting better, if not changing the treatment. Often there's not time in a few visits in a system to deal with that. So for these kinds of conditions, having some team collaborative care augment sort of the care that the primary doctor does, much through telephone based. Has there been an increase in the last year since the pandemic? Yes, particularly mental health conditions. There has been an uptick, okay? But they've always been among the more common conditions seen. And even after the pandemic goes away, there will be a role for virtual care by telephone, and collaborative care lends itself to that. Collaborative care trials have been around a couple decades. Again, they first started in depression. There's probably been 70 trials of collaborative care in depression. In the last decade, there's been more trials on things like pain and anxiety, and even some on substance disorders. But one of the barriers to uptake in healthcare systems, frankly, has been reimbursement. I mean, it's been unclear, to what degree payers will pay for this extra collaborative care, even though it's been shown to be cost effective. I think that's been accelerated a little bit because there's been more virtual telecare done the last year, and I don't think when it comes back, I don't think it's going to go back to where it was. So what prompted me to write this piece is because we've been doing collaborative care trials probably 10 or 15 years. We're not the only one. There's other groups that have done it, but and this particular piece was to kind of put together practical suggestions for actually implementing this in real world practice. That doesn't come through in the research studies all the time. So you might look at it as sort of a guide for how to use this in the real world. I see growth for it. I think where it's had bigger uptake is in what we call integrated healthcare systems. So let me give you an example. I spent about a decade working in the VA hospitals. VA hospitals is you have a population of patients to care for. Other integrated healthcare systems, Kaiser's a good example of that. There's other integrated healthcare systems. So where you're taking care of a population of patients, there's an incentive to, take care of their problems, do by phone what you can do by phone. If it reduces healthcare costs, if it improves, satisfaction and outcomes. In a standard fee-for-service model, I think what's going to get more uptake is by reimbursement mechanisms for it. Medicare has taken steps about 5 years ago. There's now an extra code if you're delivering collaborative care that you can bill for. So I see growth. There's been growth in the integrated healthcare systems like federal integrated systems, VA and military, and private integrated systems that you have mentioned. But I think in the fee-for-service, I think the extra reimbursement that will persist after the pandemic wears down for telecare, I think that's where the growth or in uptake will be. No, I think the other message for this is, how do the patients receive it? Generally, we've done satisfactions. They like the extra attention because between visits, this is kind of what you might say a between doctor visit service, where they get some extra calls, especially when you're initiating treatment to make sure it's going well. I think physicians find this service useful because they often, the mechanism for frequent follow-ups in the first couple of months is not there. So I do think that that's both patient and provider satisfaction will seem to be good with this.